new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. Coming in 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available. But please use the all-access pass if you need to claim CME credits. Thank you so much.
And we're live in 5,
4, 3,
2,
1.
Well, good evening, everybody. Today is January 14, 2025. Happy New Year to all of those of you who I've not seen and we've seen before from Seattle, from our beautiful Seattle Science Foundation studios. And for those who are disappointed to not see Cornell here, they had a short-term conflict, so we gladly jumped in. And I do think and I hope that tonight's topic will be interesting and provocative. It's dual cages in the thoracolumbar spine reconstructions. And I welcome, as always, our wonderful colleagues from the Texas Back Institute. I saw Rick Geyer in the speaker room, and Jack Ziegler, I think, is just logging in right now. And my partner, Dr. Oskuian, will be up shortly. We're here with our great team at SSF. Ben at the controls and Corey is moderating everything. And we have a young medical student here, and I may pimp on him and ask him for his thoughts as a medical layperson, kind of as a non-spine surgeon, if I may. So dual cage is the topic, but before we get into that, quick advertisement for tomorrow morning. We have Dr. Prasant Rao from Sydney, New South Wales, Australia. They're talking about SI joint fusions, and he does robotic implantation, but he does endoscopic augmentation of fusion. So he combines arthrodesis principles with sound new engineering. So we're very curious about this. And just as a completeness sake, we do not advertise for unconsiderate fusion surgeries. This is, again, a slide I frequently show to show the abuses of spine surgery. And I'll be very curious how he responds to this. We have a couple of cases from our fellows also. This talk tonight is not a high-tech future spine surgeon talk with robotics. It is craftsmanship, and these are our wonderful fellows who will present tonight. My partner, Dr. Oskuian, just finished in the OR, and I'll ask him to come straight to the podium because we're going to talk about far lateral surgeries also. So, Rod, thanks for coming straight out of the OR. Our fellows, Mark, Nick, Colin, Cameron, depicted here, are going to show up. And if Nick's a little bit giddy, he's an Eagles fan and a birthday boy. So happy birthday, Nick. Actually, he's not in the room yet. So the question about dual cages will evoke a very predictable response, and that's why. And again, the three core principles of spine surgery are effective decompression of compromised neural elements, physiologic realignment of the spine, and sound fusion. And the latter two are principles that we will submit under certain circumstances may be a very useful and safe way to do it. And again, our fellows have an unbiased view of this because they've just seen these here. But the merit of an anterior column that is intact can be seen in this failed short segment burst fracture from my Harborview days, where a cage came to the rescue. And again, a well-placed cage nowadays with expandable technologies is a very nice thing. Going anteriorly is fraught with a well-understood complex vascular anatomy that can turn a spinal reconstruction surgery under certain circumstances on life and death surgery. And again, considerations are significant as we just face a very simple spine when there are little things in there like calcifications in the vessels, prior surgeries, prior trauma, blunt trauma, etc. So vascular anatomy can be very tricky, and again, it is somewhat variable. So for 4-5 and 5-1, and I'll count on my Texas Back Institute people who are absolute artists in anterior exposures, this can always be a little bit interesting because the vascular variabilities can be substantial, and we'll see that here. I'm going to make a pitch that a simple posterior midline approach for certain situations may actually be a very servable one, and the advent of expandable cages has really expanded our abilities to kind of recreate an anterior column if the size match is correct, that is the end plate size match. And Rod, why don't you come up front here? Yeah. This is my partner, Dr. Rod Osgood. He's the chief of our spine service. Far lateral surgeries, he's one of the artists of far lateral surgeries. So these are some of your slides. Actually, why don't you just click through those?
Yeah.
Why is far lateral surgery less than straightforward?
So the main reason is because you have the lumbar plexus. And I think, for me, that's the most challenging thing of doing lateral. So I think probably the reason why we didn't do as much in the past is because we didn't have neuromonitoring, we didn't have all the tools and instruments that we have now. And expandables have changed the game too. So you don't have to make a huge incision. You can map the plexus as you guys showed here, and then get in a nice big expandable cage. So that's really the main reason.
So these are all your old slides.
Yeah. And again, I mean, I think the most important thing for me when you're doing lateral surgery is understanding that that big piece of muscle called the psoas actually has nerves going through it. So you've got the lumbar plexus is going through there, and you have to understand the anatomy and then know that, you can't just go in there and take an osteotome and go through the psoas, obviously. So I think in our experience here and doing this over the last 15 years, that's the most crucial part, is understanding that anatomy. And every patient is different. And there's some nice slides that Jens has put together, and some of them are from our previous presentations. But know that each one of those nerves goes to a muscle. They're either motor or mixed nerve roots, and they all need to be preserved. And so I think that's an important part of doing lateral.
Here, why don't you stay here? So these are some of your old slides, but in principle, we have some newer papers on the lumbar plexus. And again, we have this zone system that you've helped create with others, but this is still something problematic. How did you handle this from an anterior approach? So this is a case of yours.
Yeah.
And how do you do this safely?
We actually, it's funny. So in a case like this, obviously, it's a patient who had a scoliosis surgery and now developed a pseudo. And we carefully mapped the plexus and did an interbody fusion at each level. And the powerful thing about doing lateral is you can get a really nice indirect decompression. So for a case like this, if you're able to get, again, I think this was like an 80-some-year-old patient. I actually remember the case very, very well. If you look, and I had some nice images, but you can see the foramen on the one side is gone. And the patient has pretty significant coronal deformity. And you can see that's what the x-rays look like. This is what we ended up doing, is a 2-level interbody fusion. And you can see it's not perfect, but you can see the coronal images are you have a little bit better alignment. And then more importantly, the nerves are decompressed. So I think this is where, again, someone who's had multiple anterior, posterior operations. And then I did this laterally, and she's in her 80s. I did a posterior fixation later. But I think this is the key, is understanding the anatomy in these relationships and understanding that these nerves actually have distal function. So, you've got all the proximal, distal, lower extremity nerves, and you can have all sorts of complications. You can have both visceral injury, you can have abdominal injuries, and we've had them all. But again, with neuromonitoring and navigation, I mean, things have gotten better and better and better. But like any procedure, every surgery that you do has its risks and benefits.
So what do you tell, before I let you go, what do you tell patients in terms of how many % of patients get some form of like here we see an L3 palsy on that thigh, we see an abdominal pseudo hernia. how many ilioinguinal problems, how many patients get an adverse neurologic event from a lumbar plexus injury from an XLIF or far lateral procedure?
So the complication rate is, for nerve injuries, is pretty low, but when you get it, it's devastating because it's like a peripheral nerve injury. You knock out multiple nerve roots. I'd say, unfortunately, the literature isn't as clear. I think people tend to underreport. So in my honest opinion, doing this for the last 15 years, I've done over 1,000 levels, and I've had probably about 6 or 7 femoral nerve palsies. So it's not huge, but it's there. Other nerve root injuries, absolutely. I tell all my patients, you're going to wake up with weak hip flexion, hip extension, knee extension, because you're going through the psoas, the lumbar plexus gets irritated. That's 100% of the people. And then what drives them crazy is the anterior thigh is numb, and that's from the general femoral nerve, and that's in 100 patients. So we almost 100% of the patients, we give them gabapentin. Sometimes they need SSRIs. Most of the patients' symptoms are usually resolved by 3 months.
So, yeah, this didn't take you, but, oh yeah, here. This is a patient with multiple previous anterior surgeries. Do you have any apprehensions of going back in a far lateral approach on the same side? If this patient needed a far lateral procedure, is that something you'd be comfortable with on that same side?
So this was a far lateral approach. I
3 of them.
tend to go from the opposite side, but there's nothing wrong. I have gone through the same incision. Because you're quote unquote going through the retroperitoneal space, it should be okay. But again, I get an abdominal CT, and if there's any question, I go to the other side.
Stay. So this was a study done by one of our former fellows who actually extracted through a 3D printer the lumbar plexus in a patient through a conventional MRI scan. So this again just shows how diffuse the lumbar plexus is, and all these white things are the remaining discs. Did that change your practice? I've seen you done far less far lateral.
No, I mean, I think honestly, I've always, just because we've done so many of them. In fact, we wrote the only and first book on the lumbar plexus, the surgical anatomy of it. I mean, it's daunting when you look at it with a view like that. It hasn't really changed. I think what's changed my practice is navigation, robotics, expandables. I mean, you can do a lot of work through a small hole. And so we just did a corpectomy about a month ago in a young patient who had a really significant traumatic burst fracture.
So this was, I have one of our combined cases coming up here, but this is a case that we recently had, a patient who had multiple surgeries. I forgot how many they had, 9 or more surgeries in an outside hospital in a different part of the state, multiple rods on the back, everything blew apart. And we see, what happened here? Do you know what happened at the T12L1? There were multiple far lateral surgeries done. How did this
it didn't fuse. So, clearly the patient has, pseudoarthrosis there and instability. I think the rod looks like it fractured right at the thoracolumbar junction.
Rods, 6 rods.
Yeah.
6 rods. And there's an intradural heterotopic ossification that grew in there. So this is a pleasant, and she had a rod sticking through her skin. So, so we didn't do dual cages here. We did a simple costotransectomy. We put a much larger cage in here. We got a good interface. She had infections. She had a pseudomeningocele here. We repaired that. So she's actually doing very well. The problem for going through a costotransectomy is obviously in the lumbar plexus where we're here, this can be a problem. And when we have revision exposures, large habitus, complex deformities, infections, radiation, those are all things to not do. This is a case in your clinic that you showed me.
Yeah.
And I'm going to ask Dr. Guy, or maybe put him on the spot. So this is a patient who's 64. She had breast cancer. She had radiation for an L4 lesion. And an outside surgeon did a right-sided far lateral surgery and a left-sided far lateral surgery. And now we have this. Any thoughts? Would you be, you're an artist in going anteriorly. Would you and your general surgeons go anteriorly in this, Rick?
No, Jens. First of all, I don't think I could convince him to do that. This is one that, I think the risks are too great compared to the far lateral, even though you talked about the, lumbar plexus injuries. We wouldn't attempt to do that from the front.
Even with
At
your,
least I couldn't convince him to, and I wouldn't.
Dr. Ziegler, any different opinions?
No, it's the same thing, Jens. Particularly with radiation to the retroperitoneum at L4-5 and breakdown and motion. I don't think our surgeons would be interested.
Yeah, so she is kind of bouncing around right now. Dr. Osgood, we're going to not say what we're going to do. Are you going in from anterior? Do you want to look at dual cages maybe? This is a clumsy lead into our topic tonight.
Yeah, I mean, I think honestly, I haven't really decided on what we're going to do. I think everything's on the table for this one.
So maybe we can convince you in dual cages. There's only one paper out this by Alan Daniels from Brown. Very conflicted, love the guy, and obviously love Brown. But he wrote a single paper on 2 cases. These are the cases I extracted from his article. So it's not exactly high science. He did one at T10 for a tumor, one at L1. Arguably, I don't see a reason why we can't do conventional large expandable cages there. Again, I'd use PEEK personally for a tumor, and for trauma or infections, we use titanium. But that's what the literature says so far. And again, the justification for that extra expense in his eyes was improved anterior column stability, decreased lateral exposure, and resection trajectory. But can we put these through the lumbar plexus, through the interlaminar space? So long lead in. Cameron, take the lead now. This is their expanded spine curriculum on the golf course, but the virtual golf course. Do you know where your lecture is? I'm going to look for it. You this one? Okay, Cameron came to us. This is a great lead-in for our Texas colleagues from Dallas, Texas. So he is a DFW product.
All righty. Thank you for the introduction, Dr. Chapman. We'll get right into it. This is a 81-year-old male, he had worsening back pain presenting and bilateral lower extremity radicular pain. He said it was difficult to stand upright or walk more than 10 steps due to his pain when he presented. He now requires a walker and wheelchair for longer distances, previously independent ambulator. Does have a significant surgical history noted by previous L1, L2 compression fractures that underwent kyphoplasties in 2020, followed by a lumbar laminectomies radical in 2021, and presented to us 1 year later. You can see his presenting scoliolateral full-length film there on the right. And past medical history, AFib, high blood pressure, you can see the rest there. And his social history was a former tobacco user and quit over 22 years ago. So you can see there on his sagittal full-length films, he's tipped over in pretty significant kyphosis, just very osteoporotic. I had no bowel or bladder symptoms. He reported bilateral thigh and growing numbness and paresthesias. BMI 27, as reported, ODI was 72, workman's comp crippled, and his DEXA score was a -3. You can see there on his AJA exam that he does have some hip flexion and knee flexion weakness, a little bit worse on the left there. And then he does report sensation changes and hyperesthesias there and bilateral anterior thighs going into the groin as well. No long track signs. So going back to his initial films and just stepping back and looking at a chronological depiction of and progress of his management. This is his films after he suffered. There you can see L2 burst fracture with subtle L1 superior end plate compression fractures. He subsequently went after 2 weeks and underwent kyphoplasties, as you can see there, both of those levels. This is a film from about 1 year out from his kypho. He did relatively well from that, but did start to get worsening back and bilateral leg pain, consistent with neurogenic claudication and radiculopathy. An MRI was ordered. I'll go through this real quick. There you can see L1, L2, central and foraminal stenosis with some L2 collapse. Here's a CT scan of around that time as well. So bony cement component of stenosis L2, severely osteoporotic, about a Hounsfield unit at L1 of 50 and or 212, excuse me, and we know less than 100 is pretty problematic. So just in summary, at this point in time, is 81-year-old male, worsening back and bilateral lower extremity radicular pain. He's status post those L1, L2 kyphos that did okay for a year. He's now failed injections, conservative management. He has that stenosis we can see on the MRI. What are we thinking treatments-wise?
So, Jack, I'll start with you. This is a common problem for us now. Senile insufficiency fractures with secondary spinal stenosis in the lumbar spine, sometimes the thoracolumbar junction. He is very unhappy. This is a highly functional person, very well to do. Any thoughts of what to counteract this with now? High-grade stenosis.
I mean, you've got to fix what you can, decompress him and then try to get whatever stability you can with his poor bone quality. So just a wild guess would be a double cage and posterior fixation, but that's just my hunch.
I wonder why you got that. We're not quite there yet because other surgeons were treating him. I have no problem with initial burst fracture. Rick, do you have these severe osteopenic fractures or osteoporotic fractures with secondary stenosis in Dallas? And who in your group treats those? Do you have a whole osteoporosis management system?
Actually, Izzy, who's not on, he has his PA that actually has a bone health clinic. And so we send all them to Izzy, and, she'll get them on either Forteo or one of the other drugs that they can get approved. And Izzy's very aggressive with them, but we send them all to him, fortunately.
This is one of those things that all of us struggle with. Ours is going to dissolve here because we've not hired a new person and they're going to quit. They're going to retire July 1st. So I recommended, just in the interest of time, a decompression, but the patient was in another part of the state. And they did what?
Yeah, so we recommended midline sparing decompressions and possible interlaminar stabilization device versus even fusion, as discussed. He went to an outside provider and had these radical laminectomies of L1 through L3 done. And you can see his x-rays there on the left, and then his lateral x-ray there on the right, which was about a month out after the laminectomies. You can see the absence of the spinous processes there, and you can also already starting to see his loss of lordotic alignment and even tipping into kyphosis there above at the thoracolumbar junction.
All right, so now he's getting really happy.
Yeah, so very minor relief, only for maybe a month with return of symptoms. And here you can see he's tipped into about 12 degrees of kyphosis with even further collapse of that L2 burst fracture.
All right, so now we have a insufficient anterior column, and we have a still retropulsed burst fracture, and we have a full laminectomy, so whatever was left of a posterior tension band is gone. And why don't we maybe ask Dr. Guire, because Dr. Ziegler has already positioned himself, what should we do here?
Well, Jens, re-image, obviously, he still has stenosis. He's unstable. And you already got cement in at least the right side of the upper vertebral body, and the center vertebral body is, well, you got it sort of diffusely there. So unfortunately, you hate like hell to do it, but it's almost like you have to do a corpectomy. And I don't know if you can do it laterally, Jens. There's not a hell of a lot you can get at the inner body space, at least at the upper one, because it's compressed, you got cement, and I don't know what kind of cage you can get in there to try to get him stability. Plus, he's already fallen into kyphosis now.
Rod, we talked about this patient at the time. You're a master of far lateral surgeries. This is a simple level. This is L2. Would you have been comfortable in retrospect to do one of those prone corpectomies and get that cement out, get that retropulsed fragment out of the dura, or is that just a little bit asking too much?
No, I mean, we've done a bunch of these.
But this is a healed malunion, non-union.
Not a problem at all.
At the time, we kind of discussed it, and I think we just said,
I think he stole the case from me, if I remember correctly.
I stole them from you, yeah. So let's see what we did.
Yeah, so these are our intraoperative views. And so we proceeded with a T12 to L3 posterior fusion with cement augmentation of all the screws, and then UIV +1 and LIV -1 above and below the fusion construct with, you can see there, an L2 corpectomy with bilateral titanium expandable cages, all posterior, obviously nerve root sparing.
And yeah, let's move forward then.
This is a post-op CT.
So my thinking was I did not want to sacrifice his L2 roots or stretch them. This is, at this point, I'm a pretty, very unhappy male. I wanted to give him a comprehensive neural decompression, and we wanted to give him a relatively short segment fixation below, not go to the pelvis. And we did LIV -1 and LIV cementing and LIV +1 cementing to give him some transition, because he had also not been placed on the recommended anabolic medications. So this was this, and let's fast forward. So we did a dual cage. My thinking was to put them as close to the apophyseal ring as possible to have the best possible mechanical fixation. And he's 2 years out now, right?
Yeah, so he's this is a long-term follow-up. He's about 2 years out, and he was pretty happy, very happy actually with his surgery and his results so far. He left a nice message to the clinic staff, an epic message there, just wanting to thank the whole team. Zodi significantly improved, cut in half, down to nearly below 40, and he's doing the recumbent bike exercises, walking for a few miles, even swimming, and sidestepping on his own with exercises. So
I was not pleased that he collapsed a little bit, but he has not ever complained about his alignment. So compared to my initial alignment, he's kind of sagged a little bit. Again, my thinking was least possible alignment. Jack, from your end, should I have gone more levels, or in these very osteoporotic patients, do you subscribe to the less levels and some anchoring is more?
No, Jens, I mean, it's a good idea to try to spare him some motion, but I'd be really worried about fixation and healing. Obviously, you guessed right, or you're smarter than I was, and you got away with it. I was going to ask you what biologic you used. Did you use infuse here, autograft, allograft, expanders? You know, what did you use anteriorly and posteriorly?
I think we just used local bone graft. There was no oncologic disease process, and I used something really high-tech allograft chips, and that's it. And he actually looks totally healed. So
yeah, you did great.
There was a clear, yeah.
And Jens, he was never put on Forteo or anything else?
I think we got him on it finally, but that was post hoc. I mean, he literally became more and more bedbound, and then the family became more and more involved, and he was put on increasing doses of opiates until they transferred him over from the eastern part of the state. So we kind of, this is one of those things where just from the beginning, everything needs to be done right. The first kyphoplasty hopefully is done within 3 weeks. Patients are put on a bone health program like what you have through Izzy's mid-level, and then are followed by bone-savvy people. And the problem of the secondary stenosis is one that's particularly vexing. Here I did not see any other option. Sadly, the full laminectomy that another surgeon decided to do was not at all what I had in mind.
Mm-hmm. Yeah,
I think most people would have just gone a lot longer. So I think it's remarkable restraint you showed and got away with it. But you know, I think most of the spine surgery we see done elsewhere that's failed starts out longer than this, and they still get, you know, proximal or distal failure. So, you know, congrats, kudos.
Got away with it, but yeah, I was obviously watching those L3 screws like a hawk, but got away with it. Shall we go for Colin next? So thank you, Cameron. Good job.
welcome.
The only, Jens,
Yeah.
the only issues I've had with, I've done a couple of those bilateral, is that, is just to get the, sometimes you get a little subsidence, and, you know, like the end plate coverage isn't good, but obviously you can't sacrifice nerve roots. Do you have any tricks for trying to get the cage in and position correctly?
You have to put
or
them in
anything?
horizontally and then turn the cage.
Oh, you put them in horizontally. Wow.
And then twist them straight. I use a temporary distractor on the end plates, and I tried to seat them on the apophyseal ring, so not in the center cavity, but on the
ring.
left and right, and then try to balance the left and the right cylinders in expansion and avoid overexpansion, which is, because it's very powerful, very possible. Dr. Gold is a neurosurgical colleague from the University of Iowa, and he's still not signed a contract. He's good as gold, like his name says, very, very appropriate name. So take us into a different angle of a complex case.
All right, so this patient is a mid-30s-year-old man who presents to the emergency department with 3 weeks of progressive low back pain that has become to the point that is now severe, preventing him from doing much walking at all. The patient was working in Bali in hospitality until he was recently hired as a cruise ship worker and showed up in Seattle. The patient, at the time of the emergency department, denies any perineal numbness, bowel or bladder dysfunction, is ambulatory with assistance as well. He's neurologically intact on exam with the exception of a positive right single leg raise test. Here is some imaging. On the left, this is a T2 MRI. You can see there's a mass centered in L5 with epidural invasion, and then also ventral involvement in the retroperitoneum. Seems somewhat destructive of the L5-S1 disc space. And this is a post-contrast T1. You can see this is contrast enhancing with a cystic component, especially going into the ventral area in the retroperitoneal space. And we have a, if I can get to it, CT scan as well. This again demonstrating the severe destruction of the L5-S1 disc space. Doesn't really involve the posterior elements.
So an infectious process, purulent material, but negative microbiology. This is a somewhat neurologically compromised patient. He is basically unable to get up. So we had a L5 destructive lesion of unknown origin, and we decided to proceed with surgery. What would you have done in Iowa, hypothetically? You have an L5 infectious process of unknown origin. Would you have waited until more cultures come out? I mean, I think we waited for 3 to 5 days or something like that.
Yeah, so there were multiple cultures in this scenario, and all of them were negative. I think only one actually grew the pathogen of interest. But I think ultimately we would have done the same thing, CT-guided biopsy, and then proceeded with probably posterior surgery, and honestly, probably the same deal.
Would you have done dual cages?
Yeah.
Okay, then same construct. Let's take it forward.
Yeah, I think it would have been hard to do lateral here because the iliac crests go pretty high here in its L5.
Rod L5 corpectomies from a far lateral approach.
That would be extremely challenging.
Is it the iliac crest? Is it the vessels? What's the
Both.
problem?
Both.
What about those oblique interbody approaches for an infectious process?
I think oblique, so ALIF, oblique potentially, but I don't know. I think probably just do a standard anterior, where you have good, I mean, the whole vertebral body needs to come out here. So
Yeah.
I would just go from the front.
So for me, one of the biggest challenges is, and I've done a fair number of L5 corpectomies with the help of great vascular surgeons. Shout out to Dr. Ben Starnes in my Harborview days, and to Dr. Andrew Ting and Greg Hayes here. But those are hard surgeries. What about you in Plano, Texas? So L5 corpectomies, you have artists, surgeons who do these. Does that fulfill you with a little bit more trepidation because if you have to work through 2 separate windows, or what are your thoughts on doing an L5 corpectomy from the front? Randy Davis is online. He's asked what to do. I wish he's in the room. Are L5 corpectomy something that you're comfortable with infection patients?
Well, we've seen more, not seen a lot, but we've seen more for trauma than for infection. Again, it's different patient population. But a lot of it also depends on the vasculature. Some L5 and L5-S1 disc spaces are relatively easy if everything is very lateral and you have a big anterior window. But sometimes with a left iliac vein that can be draped across the entire front of the L5 body or the L5-S1 disc space, that can be one of the hardest operations you do under clean circumstances. Then when you put in, untreated purulence, it's anybody's game. But as Rod was saying, at least you're visualizing everything straight on, and you should be able to get reasonable control of the vessels and address any issues through an anterior retroperitoneal approach. So that's likely the way we would approach this as well.
So Randy
Yeah.
said, yeah, go-
And I think because it's infected, as Jack said, with the purulence, it's not like you're digging out all bone. This is going to be mush when you get in there. And although you don't like, retracting sometimes that left iliac that's right over the disc space, at least you can work under it and hopefully you can scoop it out relatively easily.
so I think Colin said he did something very similar. By the way, Paul, he suggested rib allograft to fibula allograft posteriorly in the previous patient and probably also in this one. I like that technique. We didn't use it there.
Yeah, so the surgery performed was L3 to pelvis, posterior instrumentation with quad rod construct, L5 posterior corpectomy with bilateral expandable titanium cages, use of BMP, and then mostly just irrigation of this retroperitoneal abscess through the disc space. And this is the post-op CT, demonstrating the bilateral expandable titanium cervical cages, pelvic screws.
If I'm self-critical, one of those cages is tilting a little bit to the other one, was buttressing the other one, but we did a quad construct there, so a short segment fixation around the corpectomy and then a neutralization fixation.
And the patient did well. They discharged home to Indonesia on RIPE therapy about a week after surgery, which was for 6 to 9 months. And the intraoperative pathology, if the RIPE therapy didn't give it away, was TB. I think 1 out of 7 cultures grew TB.
So Dr. Pauly again points out, if you go anteriorly in these complex things with inflammatory diseases, you might want to think about ureteral stents, you might think about vein stents, because and I've been there, the inflammation around those retroperitoneal structures is pretty prohibitive and can be just daunting. So yeah, so this was a infection case. We were not sure what we'd encounter there. We thought it would be infectious, but until we had large scale samples, we didn't know there was TB. And then all of us had the pleasure of getting repeat TB testing for about a year afterwards. So
Actually, I did have a question about this pathology. So I had an attending in residency from Korea who said that he had a patient with, I think it was thoracic TB involving the vertebral body, and did a lateral approach for corpectomy. And essentially the infection eroded into the aorta. And when they opened, there was open aorta. Patient died on the table. So I was wondering if this was something anyone had experience with this being erosive into vessels.
I have not seen that. I am just worried about having been in horrible retroperitoneal exposures for infections. I try to not go in there anymore. And that goes for Charcot arthropathy also. It's so nice to do an anterior column reconstruction from anterior, anterolateral. I am not happy with the prospect of going anteriorly anymore after having spent hours with desperate attempts at trying to get adequate exposure windows. So that's why I was very happy with this. I'm far happier and had no neurologic deficits. Again, you have to put the cages in horizontally and then twist them. And again, here we didn't do the most beautiful job, but it seemed to hold up okay. All right, so next, Dr. Kramer's coming next.
Jens, if you have a high pelvis and a deep L5S1, do you have room in that V to do your decompression and put the cages in?
Yeah, so I measured the cages with a little dowel, and I look for the largest windows. Sometimes it's a 4.5, sometimes it's 5.1. We try to protect them with small little neural retractors and then slide it in. But again, I measure the interval and look at the widest one opportunistically. And sometimes it's 4.5, sometimes it's 5.1. But we just did one, and I think Mark just did one of those cases he's going to show next.
Yeah.
So Dr. Kramer, Madison, Wisconsin neurosurgery grad, glad to have him here, and looks like he might be joining us. So tell us about this gentleman's story.
Very good. So we have, it's a case we actually did just a few weeks ago. It's a 75-year-old gentleman. He presented with severe low back pain. Back pain also kind of radiated into his buttocks and proximal legs as well. He has a history of a discitis, which was treated non-operatively. This is about 18 months previously. This was just treated with antibiotics and no operation was done at that time. The culture was based on blood cultures at that time. He's got a history of stroke, so he's on Plavix. He's also got a fairly complicated past medical history. He had some alcoholic cirrhosis, he had peripheral neuropathy, he had kind of some chronic ulcers on his legs. He also had a recent diagnosis of colon cancer, which was treated with some immunotherapy, and he's under surveillance at this time. He had bilateral hip replacements, and he's had previous ACDF for cervical myelopathy. So this exam that he came in with, he was intact, but again, very pain limited, and severe back pain, no pathological reflexes. So here's his standing films. His pelvic incidence is somewhere between 50 and 55 based on my measurements. His pelvic tilt's 21, lumbar lordosis is low at 20, so fairly large PI-LL mismatch. His SVA is 15 positive, so quite forward tilted. And as we can see, based on a CT, doesn't have severe coronal deformity. In fact, his coronal balance is quite neutral, but based on the sagittal CT, this is the current CT, not the one that was done back at the time this infection was diagnosed. You can see that there's a pretty significant collapse of that L5 vertebral body, about 50% or less, especially anteriorly there. And he's got some mild stenosis at that 4-5 level, but no severe impingement above. And bilateral foraminal stenosis at 4-5 and 5S1 secondary to that vertebral collapse. So in summary, approximately 75-year-old gentleman, 4-5 discitis, treated non-operatively about a year and a half ago. He comes in with this L5 compression deformity and a pretty severe lumbar lordosis PI mismatch.
So he's cleaned up his act. He's no longer actively taking alcohol. He has very large veins. He's had colon cancer. He's had several treatments. He's now on immunotherapy. He's leads a very active lifestyle. He has a progressive disease. I followed him for a year, I think 1 year, right, or more, 36. It's quite a while that I followed him. I did not really want to operate on him, and he kept coming back to me and knocked out one contraindication after the other. So he's done his homework. He actually said it like that, and he has DISH in his lower thoracic spine. Any thoughts? Anybody? Randy is not ready to roll, but do you want to go anteriorly in this setting? Rod, do you want to do a far lateral procedure?
This one I think would be tough because of the crest. I probably would want to do, I think an ALIF, 2-level ALIF is what I would vote
Colon
for.
cancer. He's had colon cancer. He's had every treatment in the world for this. He has a large abdomen.
Yeah,
He's a former
I mean,
alcoholic.
I would, again, I mean, we've got great access surgeons. I would, I would trust our access surgeons to get us there.
All right.
I guess the other question to ask would be, 18 months ago, what would, I know this is not osteodiscitis kind of case, but should this have been treated differently 18 months ago?
I mean, for me, the key pathology here is understanding not just his systemic illnesses, but his DISH. And so he has this spontaneous fusion of his lower thoracic spine, including the upper lumbar spine. And this is now a kind of a merger of a mechanical instability plus an infectious disease process, which is probably opportunistic. He had rotten toenails that actually had him take his toenails off. He did everything, cleaned up his diabetes act and everything. But yes, if you see DISH, you may have to really think about a preemptive fusion, and then just filling in that gap would be a far easier surgery. What would you have done in Wisconsin? You have a fairly active spine center in Madison?
Yeah, I think, a conservative approach, as was done in this case with IV antibiotics alone, probably would have been the initial approach for that initial presentation. With his now advanced kind of collapse, I think a lot of the surgeons that I worked with probably would have preferred an anterior approach.
So staying with the topic, we did a dual.
Hey Jens, it's Amir. What about a 2-level IDO from the back?
We don't have the CT anymore. He has the worst oblique disc collapse imaginable. He has like a lateral subluxation. The coronal he has actually probably better. I'm an IDO fan. Is this the last CT? Because there's one CT which shows basically his spine is just laterally collapsed. So
It's probably just the cut.
yeah.
Yeah.
But I was not happy to try to pry that apart. As everybody knows, I like IDOs, and absolutely fair. When we got in there, I was actually, this is retrospective justification, I was very happy we did not have that, and that we had planned for a L5 corpectomy.
That's right. So we did L5 corpectomy, placed 2 cages, 2 cervical titanium cages, and we were able to nicely decompress all the nerve roots, 4 and 5. And we did a quad rod construct. So the kind of working rod between L4 and S1, and then the primary rod extending up from T10 all the way down to the pelvis. And we had a very nice result. I'll scroll through the CT here as well.
So this is your first time that you did a dual core rod. And again, just speaking freely here, how hard was it for you? How were your impressions of this? I'll close my ears if you want to, but.
I would say, you know, you understand your anatomy, and you have good surgical technique principles. It's a very doable surgery. I think what adds challenge to these cases is when there's a revision, when there's already been some work done on that level. That adds a lot of additional risk, I think, to you know, getting the access you need to get into the front. But even in those cases, as we've seen, it's certainly possible. But I thought it was a very I thought it was a great surgery, a very reasonable approach.
Yeah, and he did actually, how did he do?
He did very well. He's admitted to rehab. He's still working on mobility. He was quite debilitated preoperatively, as we discussed previously, but he's gaining strength and doing very well.
So I got to tell the audience here, and thank you all for your input. The vast majority agrees with Dr. Skuyan. Randy Davis just texted, yes, anterior corpectomy. So I'm just a wuss. I like to go on the backside. Let's switch, thank you. Let's switch to Issaquah, and if there's time, then we can go to your next case. We'll switch to our hospital in Issaquah, where my partner, Dr. Mia Abdul-Jabbar, is, and our very proud, thank you, Mark, a very proud Phillies fan is there, Nick Minasali. He's from Jefferson Health, and he's doing a great job, and he's currently on Dr. Abdul-Jabbar's service in Issaquah. And I'm not the only one who's sometimes not happy to go in the front, so I'm happy to say that Dr. Abdul-Jabbar is also somebody who uses dual cages sometimes. Amir, Nick.
Can you guys hear me okay?
Yes, hear and see.
Awesome. Perfect. All right, so I'll get started. That's me. Great. So this patient was a 60-year-old male who was admitted at an outside hospital. He presented there with 2 weeks of progressive acute on chronic low back pain with left buttock pain, worsening ambulatory dysfunction. Upon arrival at that hospital, he was found to have an L2 spondylodiscitis. Unfortunately, they tried to treat him non-operatively, obtained CT-guided cultures, which were largely negative. And then, you know, after several weeks of inpatient treatment with IV antibiotics, our hospital was kind of consulted, and they felt it was a little too complex. So that's kind of his background. As far as past medical history, he has idiopathic eosinophilic syndrome with erythroderma, which is basically kind of an autoimmune type of reaction that causes severe skin rashes. So he's chronically on prednisone 30 milligrams daily, as well as monthly mepolizumab infusions. And in other history, he had a prior flexor tenosynovitis IND 6 months prior. So certainly a complicated history. As far as BMI, 21, non-smoker, social alcohol use. And as far as his exam upon arrival to us was overall intact, except again, he just had pain limiting his ambulatory function. So he really was not able to get up and around due to mechanical pain. So this was imaging x-rays from his the outside hospital upon presentation. You can see this dextroscoliosis, I believe it was around 20 degrees between L2 and 5, and then loss of lordosis, even some focal kyphosis in the lumbar spine, but no overt instability on flexion and extension. And this was initial MRIs done at the outside hospital again with this L2-3 discitis, focal kyphosis, neural impingement centrally. And again, this gentleman had prior chronic back pain. So I think it's important to look a little bit outside of the huge picture here and recognize that it's not, he has stenosis outside of the problem area, and to really, identify if this needs surgical intervention as well or not based on his exam and everything like that. So I think that's important for this case. And then several weeks later at the outside hospital, he was really just not progressing, still not able to ambulate without significant pain. And so here we see even worsening focal kyphosis, bone loss, some coronal imbalance as well. Still, obviously, this is lying flat, so not quite as bad on our from our original standing films, which is also helpful for surgical planning. And then a repeat MRI. There's quite a bit of motion artifacts, so I just kind of took the two best cuts we could here. But again, significant edema within the body of L3-4. I'm sorry, I misspoke earlier, by the way. And again, that focal kyphosis. So using our site score, this patient ends up in the severe category. Even though he's fully neurologically intact, it's at a mobile region. He's got canal stenosis and a de novo deformity. He's unable to ambulate, and he has other comorbidities. So from our standpoint, again, just a 60-year-old male, chronic prednisone with osteoporosis. I forgot to mention on the CT, the Hounsfield units around L1 were in the 60s. So again, as Dr. Hogg said earlier, that's very concerning for osteoporosis in lieu of not having a DEXA scan. He does have a history of MRSA bacteremia and then this L2-3 spondylodiscitis. So I'd be happy to hear of any other options.
Nick, let me jump in. Thank you for the good presentation. I like the discussion earlier about lateral and posterior. This was a surgery that I initially planned to do as a staged approach. So do a partial corpectomy from the back and, flip the patient and come in from the lateral. I do like to do that because if the patient is unstable, if there's a lot of blood loss, you get them stabilized, you can get part of the corpectomy done and then come back once they're more stable. But, in this case, as we'll see going forward, I do think that there's other options. If the patient is doing well, you're able to save quite a bit of time and morbidity by doing just the unilateral approach. Any other thoughts from you guys over there?
Rod, far lateral. I'm looking for
I
Dr.
would
Davis.
have, I wish, Nick, you guys don't have a CT, but I'm a little worried about that end plate at L3 in order to do a lateral, but gosh, I would have loved to do lateral, go in posterior first and then do a corpectomy. I don't like those little tiny cages.
Okay. I'm all in favor of going in the back. This patient does not look like a healthy person. With these dual cages, you can actually very nicely realign the spine. You can actually expand one cage a little more than the other one. But I'm biased here.
This one would have been a beautiful one for a lateral, I think, too.
Yeah.
Potentially.
Right and or left or what?
Left.
Dr. Davis is with you. Sutton's Law, go where the money is. Nobody knows who Sutton was, a bank robber. Go lateral. So he wants to go lateral. I'd love to have Randy here online and tell us whether he'd go left or right. So what I don't like is what you told me is about this, these medical comorbidities. This is a patient who could bleed a lot. I don't want to have a small tube sticking somewhere through that psoas where this patient starts bleeding like crazy.
I don't think there would be a huge risk of hemorrhage.
Okay. All
I
right.
think there would be a lot of pus coming out of that.
Dr. Ziegler, could you interest one of your general surgeons to be of assistance there with a limited lateral approach? Do you have anybody doing far laterals actually at this point in time, Jack?
Yeah, several of the guys do far laterals. So, and I think that they would also like the that approach preferentially, as well as for the end plate coverage, as Rod alluded to.
Rick, would you take? Yep. Sorry, yeah,
I was
Nick.
just going to say, I have a question, food for thought as well. You know, these often have associated psoas abscess. Would that push you more towards lateral or away from lateral if you were in favor already?
I usually take the psoas abscess out from the back. We've actually had some pretty dramatic cases. I use my thoracoscopy irrigator for this, but I've also asked Rod, who's been very capable of that, to take some psoas abscess out where our radiologists failed with their pigtail catheters. Right, Rod? It's actually very nice.
It's a great way to drain the psoas, like you said, Nick.
Yeah, I think I agree. We have a great way of doing it from the posterior with the thoracoscopic irrigator. I'm just curious.
Dr. Geyer, at TBI, when you do far lateral surgeries, do you have a mandatory general surgeon attendance, or are surgeons, spine surgeons allowed to do this by themselves?
No, the spine surgeons do it by themselves. Initially, they always used to have a general surgeon, but as they became more and more facile, then they just started doing them themselves. And they're really very good at it.
All right. So, Nick, take us forward. So, we're on the dual cage thing. Are you going to have a surprise for us? Are you going to?
No surprises here. Really looks quite similar to Dr. Hogsett's case. So great minds think alike. The patient underwent L2 corpectomy with 2 up, 2 down, as well as cement augmentation with fenestrated screws. And, you know, no major differences here. I think allograft with 60 cc's of corticocancellous allograft, as well as a DBM putty, which is staying away from specific types. And I think it looks really good. I think the patient did overall very well from, you know, the spine standpoint. Unfortunately, there's, you know, a lot of other comorbidities and the prednisone use. And I think the patient had significant skin eruption later in the course of this treatment. From a spine standpoint, he did very well. Let's see if he'll play here.
Amir, why did you not do an LIV -1, UIV +1 cementing, just out of curiosity?
I just the very poor bone quality. I wanted to, since we had, you know, sometimes I'll do the very top, but you know, this one, you know, sometimes I will do +1, -1. But again, I thought that this looked pretty good, and you know, the poor bone quality, again, I worry about pullout more than I worry about fracture above in this patient.
Fair enough. And just one more time, why did you do a dual cage construct rather than, I mean, you're very facile with the far lateral procedure also. Why not that? Why not go anterolateral like what Dr. Davis and many others have suggested here in the talk room, Dave Pauly?
Well, I mean, I think it's very appropriate. Again, it's something that if this patient had a lot of blood loss and was unstable, I think that's a great way to do it. But the patient was stable. We did not have a lot of blood loss, and you're saving him an anesthesia event, or even if you're to flip him and do it at the same time, you know, it's closing, you know, repositioning the patient, you know, coming back through a different approach. So it's quite a bit more time consuming. And if you can get it done all in one exposure, I feel like why not?
So I think we're at time now. I want to thank everybody for their participation and our wonderful friends at TBI. It's a great new year, great new start. I don't know, maybe I'll ask Rick first and then Jack for closing comments. What are your thoughts now that you saw a couple of cases presented? I think we've done 18 or so at this point in time, and I'm not looking forward to them, but as you probably saw, these are always kind of little extenuating circumstances, and no doubt the treatment options and the consensus in the group that I saw was anterior. What are your thoughts on this? Is this a veritable technique, or should we stay with anterior principles?
No, Jens, I think that the dual cage technique is interesting, and in particular when you showed the osteoporotic patient where you tried to get it on the ring apophysis, whereas all the other expandable cages go right to the center. My question to you, though, is there not a single cage in which they have a very large end plate that will fit over to the apophysis that you could use in certain situations? I understand why you used it in the cases you showed, though.
Yeah, so this is where there's no question that the far lateral surgeons like Rod can put in huge end plates that go left to right side of the vertebra. They can literally assemble it almost on the spot and then put a very thin inside cylinder, and we can't compete with that. That one case that I showed with that disaster that we recently, with the 6 rods that were broken and sticking through the skin, we actually took the X-lift, the far lateral cage, out from the back. We cut it apart into 3 portions and then fished it out. So that was a lot of fun. That took about 3 or so drill bits, and we even got the anterolateral plate out from the back. But I'm not sure. There's nothing that I know of right now in the market that has a large end plate that can compete with a far lateral cage. Right, Rod?
Yeah, I mean, they're really not to date.
Jack, can you flash up that last slide of my talk there? Ben, in closing, Jack, we showed this case before of the 64-year-old lady who's been radiated, who's collapsed. She's not treated yet. And I'd love to see Dave, Polly's, and others' opinions also. After hearing this, should we do this from the back with dual cages? Should we somehow venture through that radiation zone in another left or right-sided corpectomy attempt with this disaster?
No, I learned something, Jens. This is a new concept for me, but a lot of these cases you showed are kind of Hail Marys, and it's sort of neat that you found a way to deliver anterior interbody construct between the roots and around the back without having to go through the retroperitoneum. So I'm intrigued. I'm a little concerned also about the small footprint size in parotid bone, but if you back it up and they heal, then you've won. And you've won on a few of these cases. So congratulations.
No, thank you. We have Dave Polly who weighed in. Thanks, Dave, for being us. And by the way, Dave, your application for retirement has been rejected. He said, I'm quoting here, fewer and fewer vascular surgeons have expertise in open, difficult vascular mobilization. He said, I would actually do it from the back mainly because I don't have great anterior access support. So this is a reality for a lot of us surgeons. Randy, for instance, Randy Davis, Baltimore has great vascular surgeons, but if you have shaky vascular surgeons, maybe it's a good idea to come in from the back and just be careful through your nerve anatomy. You got to do a wide release of those, obviously, and then very carefully go through. But in principle, with modern expandable cervical cages, it's actually quite doable, and you can size match it to the interval without stretching the nerves unduly. So, well, I want to thank all of you for your thoughts. Rod, any other thoughts?
No, I mean, excellent. I think.
What are you going to do for this lady?
I don't know yet. I think we're going to get more. I think we're going to get upright films and DEXA and more imaging. So to be
Always a good
determined.
idea. All right. Well, let's have a happy new year. Thank you all for your interest tonight. Great comments. Thanks for letting us jump in there. Ben and Corey, thanks for organizing us. And tomorrow morning, we'll be at it again. Anybody's interested in SI joints and the view from down under from Prashant Rao, who's a very entertaining speaker about SI joint fixation. Dr. Polly, I hope we can count on you there. It would be fantastic to have you in the panelist room to hear our colleague. And we have a couple of SI cases of our own. So with that, we'll sign off from Seattle. Thank you all. Be safe, be well. Have a good new year.
Thanks,
All right,
Jens.
thank you.
Great lead-in.
Thanks, everyone.
Good morning, I'm Jens Chapman. I'm here at the beautiful Seattle Science Foundation facilities. Today I'm thrilled to announce to you a new program that we have. It's called the Seattle Science Foundation VIP Platinum Experience. This exclusive package is designed to take your participation to the next level.
It includes your course registration, 2 nights hotel stay at a nice local facility, ground transportation to and from course activities. Furthermore, as a Platinum experienced participant, you'll gain unprecedented access to a world-class faculty and take part in exciting networking opportunities. You'll join us at the faculty dinner, a unique chance to connect in an intimate setting and even assist in a live surgical cadaver demonstration during the course. To top it off, we'll feature in our ssfyoutube.org videos and our social media channels and showcase your expertise and commitment to advancing medical education. So don't just attend an SSF course, immerse yourself in the full experience. Elevate your journey directly by signing up for the SSF VIP Platinum experience today. I look forward to seeing you at a future faculty event here at SSF.